Uh, Thank you, sir. Good evening, everyone. Let's have a discussion on the question number one without wasting too much of the time. Like stochastic factors in the rheumatoid arthritis. The conditions with the day-to-day activities which might predispose an individual to develop this rheumatoid arthritis. This is the question. The sense of the question is like in the option number one, is the smoking as a risk factor. All of us are aware or should be aware of the fact that smoking is the most important environmental factor for the development of the rheumatoid arthritis. And even after the cessation of smoking, once after quitting the smoking, it remains positive. This remains a possibility that even after 20 years after cessation, the patient is always prone to get this rheumatoid arthritis developed. So hopefully you get the answer that, this is the correct answer. This is the correct statement that even after 20 years of cessation, the patient might develop this rheumatoid arthritis.
The trigger of these coming to red meat are some of the predisposing factors. Also, vitamin and factors. It's also a correct statement.
As far as the third option is concerned, like viral infection has resulted in increased prevalence in the rheumatoid arthritis. If you sit in the OPD and when you see the patients of rheumatoid arthritis who have developed it recently, it's a very common condition that there is a session of a viral infection, and there is no specificity involved. Like any viral infection, any mycoplasma, any bacterial infection might predispose for the development of this rheumatoid arthritis. And chikungunya in particular in India, it is very much prevalent that rheumatoid arthritis is responsible to get developed after the episode of chikungunya. So this statement is also true. Like viral infection can result in or has resulted in the increased prevalence of the rheumatoid arthritis.
Trials it is causing a lot of cases of coming to the low birth weight is not as to high birth weight. For this,
Uh,
so many are answering
all right.
the answer. Coming to next question in front of you. First, you try.
All right. So now the next question is a clinical kind of the question where we have to discuss about the differential diagnosis and how to proceed it with the condition if you are sitting in the emergency or the OPD. Like a 5-year-old male got to OPD 5 days after sustaining injury to his right knee. Now there is a history of injury. Now after some duration of time, we'll be deciding that whether it is a significant one or an insignificant one. Now on examination, there was swelling, there was limitation of movement and fever also. You see, a fever is something which obviously is not going to be directly related to the acute traumas. X-ray shows no bony fracture. Now, this is a highlight of this question. That is the catch point of this question, that if in fact there is a history of trauma, but there are no fractures available, and now this fever which has been instigated inside the topic, it makes sense that possibly we are talking about an infectious condition. So possibly we are talking about an infectious condition around the knee joint, and it could be an infection of the joint, or it could be an infection around the joint in the form of osteomyelitis. And why the history of injury is given in this particular question? Because every time you are getting a patient with this infections type, there is always a history of injury which is given or provided by the parents. So anything that you need to ask, sir, in that particular question or the language of the question?
So when I say of patient certain understand 5 year 5 days after first differential common finding possibility swelling most common joint Third differential is management part. There is no fracture. Fracture is ruled out. The management part of this both are dangerous. Are dangerous. Both the no point of giving options. Long leg slab is
Yes,
needed.
because application of a long leg slab is for the immobilization. Had there been a fracture, then possibly we would have gone with the application of a long leg slab for the immobilization of the fractured fragments. And yes, oral antibiotics are of going to be no use until and unless the diagnosis is sustainably made. So that option number A is obviously not correct for the particular question.
Coming to option B, we have IV antibiotic. If the patient ICU. Part of the question. Shifting the patient to ICU because there is no signs of a medical emergency. So that it's not mentioned about the patient pulse rate, patient BP. So patient SpO2 is not mentioned. So we can also keep this kind of patient in the emergency ward or even in the general ward. So this is not the correct statement because of this line.
Yeah, just because of the because there is no such emergency for which, or there is no such indication for which you have to shift the patient to the ICU.
ICU.
All right. As far as this option number third is concerned, I mean, this is considered to be the most practical approach. Like, you have to start empirical IV antibiotics as early as possible and get the USG done. Now, what is the importance of that is getting this ultrasonography done. If the infection is localized inside the joint of a 5-year-old male, that could be ascertained on the USG. Similarly, if the infection of the abscess is present away from the joint, or it is involving the soft tissues outside the joint, then that can also be identified on the USG ultrasonographical examination. So practically, it seems to be the best approach immediately after you see such kind of a patient. Now, as it is very clearly known, like MRI is considered to be the investigation of choice for these conditions, but age of the patient is 5 years, and if the diagnosis can be ascertained on relatively less expensive investigations, then better to go with the USG in that particular case, because it can also make us visualize that where exactly the abscess is located. So that seems to be the best answer. The best answer, although it is going to be decided after reading the last options also.
So option D, we have urgent arthrotomy. Again, there is no warning signs, so there is no point of doing urgent arthrotomy. And drainage, this we can do after doing an ultrasound or after MRI. So the answer for this question will be option number C.
Yeah. Because if we go for urgent arthrotomy, that means you are opening the joint without any reason, and there is always a possibility that, if we are opening a window for the infection outside to seep into the joint.
Right.
So for that, we should have the indication, we should have the a prior approach or prior knowledge that joint is involved, then only the joint has to be opened. So hopefully you get the answer for this particular question.
Okay, so one more thing just I would like to add in this question is, whenever you see a patient with the knee joint involvement, like any arthritis involving knee joint, so there should be 3 differential in your brain. The most common will be osteoarthritis. But in osteoarthritis, they will give you some hint like it could be obese person, elderly person. Then this could be septic arthritis. Septic arthritis. So most common joint involved in osteoarthritis, septic arthritis, and pseudo gout. Pseudo gout, which will have calcium pyrophosphate crystals. In all these 3 conditions, remember the most common joint involved is knee joint. Clear? So moving to next question. So again, here you have to see the incorrect statement. So just read the question carefully. This is INI-CET, so you will get many big line, or you will not get one liners in there. So just see the question. First is, acute attack is sudden, unwarranted, and occurring more frequently at night with a history of provocating factors. So it can be like there are some triggers like consumption of aspirin, consumption of alcohol, then consumption of some sort of I can say diuretics. Even I can say some other NSAIDs can precipitate this attack. So this can be unwarranted, it can be warranted. So gout can be precipitated sometime without any warning sign. So this option is correct. It can be sudden. Now reading second option, sir.
In order to make the diagnosis, identification of the crystal is important. And, in the second option, it is monosodium urate dihydrate crystal. The crystal of the gout is monosodium urate dihydrate crystal. That is true. It is obtained from the joint aspirates are. Now, there are specificities which are mentioned in the question, like, is it rhomboid? Then no, the sodium urate crystals are not rhomboid, they are needle shaped. Second, is it they are weak, means they show weakly positive birefringence to plain polarized microscopy? Again, no. The crystals of pseudogout are, crystals of the gout are negatively birefringence, and there is a strong negative birefringence on plain polarized microscopy for pseudogouts, for the gout. And they are not digested by uricase. The crystals of the gout, they are digested by the uricase. So these are the three specific findings for monosodium urate dihydrate crystals. The crystal which is rhomboid, the crystal which shows positive birefringence, the crystal which is not digested by the uricase is actually a CPPD crystal, that is calcium pyrophosphate dihydrate crystal. And the CPPD crystal is the feature of a pseudo gout, not that of a gout. So that is the incorrect answer, obviously, for this particular question. But before marking the incorrect answer, actually, you have to read the other options too.
So we can read this question. You can see monosodium urate dihydrate crystals. These are the crystals of the gout. But remember, these are in gout. What we get needle shape, and here what we get negative birefringence. Okay, so that is why this is an incorrect statement. But we should read the other option too. So colchicine is stopped. So colchicine, like this is the drug which is an anti-mitosis drug, and this drug we use in acute gout. So this is having a common side effect. It can cause bloody diarrhea. So whenever like patient is complaining of diarrhea, then we should stop this drug. So this is the correct statement. Now coming to option number 4, sir.
In case a gout patient comes, then apart from the drugs, it is also important to immobilize the joint, because this joint mobility, persistent joint mobility, is responsible for invoking more pain and discomfort along with the swelling to the patient. But that joint immobilization shouldn't be too prolonged. If the joint immobilization is prolonged for a long duration of time, or it is persisted for a long duration of time, it might result in ankylosis of the joint. It might result in the fusion of that joint. And this disease could be limited by the application of the drugs, by the utilization of the drugs. So joint immobilization for a long duration of time is avoided, because it can incite ankylosis at the joint. All right. So this option is also correct for this particular condition.
So this is like a question about incorrect statement. So just a brief overview, like we should discuss some difference between gout and pseudo gout. So like these are the MCQs that they ask in exam. So if I want to differentiate gout versus pseudo gout, the first difference will be in gout, you will see the crystal. These crystals are made up of monosodium urate. In pseudo gout, these are calcium pyrophosphate. First difference, monosodium urate, calcium pyrophosphate. Coming to a second difference, when you see these crystals, the shape of the crystal, this is needle shape. The shape of the crystal is needle shape. And if you see the crystal pseudo gout, these are actually rhomboid crystals. These are actually rhomboid crystals, and these crystals, like what's are told, these crystals are negatively birefringence, and these crystals are weakly positive. Weakly positive birefringence. The fourth difference I can say in gout and pseudo gout is, understand this, the gout, the most common joint involved in gout will be first MTP. First metatarsophalangeal joint means that will be your great toe. And the most common joint in pseudo gout, this is your, like I told you before, this will be knee joint. Now coming to the management part. So management part, if you ask me the treatment of gout, so treatment of gout will be based on acute gout and chronic gout. So remember this, in acute form, our goal of treatment is to make our patient symptom free. In that symptom free means what we give NSAIDs. And in chronic phase, in chronic cases of gout, what we are giving drugs like which will have some, I can say, xanthine oxidase inhibitor. So that is allopurinol. In acute stages, we can also add steroid, and we can add colchicine. In chronic stage, we can add some other drugs like what we have. We have febuxostat, and what we have uricosuric drugs like probenecid, sulfin, pyrazone. Although they are not commonly used nowadays, even nowadays what we have some new drugs like benzabromarone, lesinurad. So what you have to remember is, like, a student, they confuse this. So remember, A for acute, A to C. In acute, what you use? Colchicine. C for chronic, C to A. In chronic, you will use allopurinol. So do not confuse this. Allopurinol is not used in acute gout. Okay, then in pseudo gout, the treatment is NSAIDs. What you are giving? NSAIDs. Okay, many of the students, they mark the answer like febuxostat, like even like many physicians' favorite drug. Febuxostat, that is the brand name, common name, Febutas that we use. So that is used only when a person is complaining of kidney failure, AKI or CKD. Otherwise, remember, allopurinol is also effective. This is having good effect. Colchicine should be stopped whenever patient is complaining of diarrhea. So these are some side effects or some question that they ask in exam, because sometimes they ask you which drug you will use in acute gout, which you will use in chronic gout. So remember, allopurinol and all other drugs other than these three. These are the drugs of chronic gout. Is it clear?
Yes, and gout is a metabolic disorder, like it's a purine metabolic disorder. Like, but pseudo gout is a degenerative arthropathy, and there is always a propensity of involvement of a smaller joint in case of gout, while a large joint is involved in case of pseudo gout. So these are the basic differences. Sir has very well explained, and this is an interesting point, sir. Sir, A to C and C to A. This is for the first time.
So one more thing, just like it's reminding me a question like this was came in last INI-CET, I guess. What is a refractory gout? So refractory gout is something that is not responding to the drugs which we have mentioned, means which is not responding to optimal doses of xanthine oxidase inhibitors and uricosuric drugs. So in this refractory gout, and second type of gout is sometime you will see the patient will develop hyperuricemia due to a syndrome called tumor lysis syndrome. Tumor lysis syndrome. So this is like whenever you are giving anti-cancer drug or radiotherapy to a cancer, or sometimes some high-grade tumor, they will break on its own, like Burkitt lymphoma. So in these cases, remember, allopurinol, febuxostats are not effective. Here, what we have to give drugs like rasburicase. Rasburicase, and the question which came in exam already, pegloticase. Pegloticase. So rasburicase, pegloticase, these are the drugs which we use in two conditions: refractory gout and gout or hyperuricemia due to tumor lysis syndrome. Clear? Okay, so coming to next question, you can see some images here.
Yes, as if it is very clearly evident, the needle-shaped crystals.
You can see these small, these are the needles, this needle-shaped crystals. And here you can see, let me highlight this, let me zoom it for you. You can see this is what we call this overhanging edges with sclerotic margins. This you can see, overhanging edges with sclerotic margin. This is a classical sign that we see in gout patient. What we call this G sign or Martel sign. G sign or Martel sign. So this is the X-ray finding that we see in patient of gout. Right? Any doubt you can ask in the comment box. We are simultaneously watching our screen so that you can we can answer all of your doubts. Okay, coming to next question. So over to you, sir.
It is again a clinical question mentioned, like 25-year-old pregnant female. One of the etiology for that condition is already provided in the question, like pregnant female. Came to OPD with a complaint of dull pain in hand and the forearm with mitigated symptoms by shaking the hand. That means if there is any change in the posture of this hand or change in the activity of the hand, then the symptoms could be relieved to some extent. Like there are significant clinical features which are being mentioned. Like there is a paresthesia in the hand. On compression of the volar aspect of the wrist, there was tingling and numbness in the lateral 1/3 of the hand. Which of the following is incorrect about the condition that the patient is suffering from? So before even reading the options, one has to be sure that what is the condition the patient or the question is being asked about. Like the question they are asking is about the carpal tunnel syndrome, and what not is provided in the feature in the question itself. One, the etiology, pregnancy, a known etiology for carpal tunnel syndrome. Second, there is a variable paresthesia over the lateral third of the hand, which is the involvement of the median nerve and the median nerve compression. Right, and On compression of the volar aspect of the wrist, the manual compression of the volar aspect of the wrist, it will provocate the symptoms of the median nerve compression, which is considered to be a clinical sign diagnostic for carpal tunnel syndrome. So by reading all these facts inside the question itself, you came to know that the condition they are asking about is the carpal tunnel syndrome. Now the first option for this is going to be explained by Dr. Aman.
Okay, so let us read the question once again. 25-year-old. So first hint in the question is pregnant female. So this is the first hint. Then you can see complaint of dull pain. So dull pain itself means that is a neuropathic pain in hands and forearm. Then we can see like there is paresthesia in the hand and mitigated symptoms by shaking hand. So means it's a case of neuropathic pain till now. Then you will see on compression of the volar aspect of wrist there was tingling and numbness. So this is like confirming our diagnosis. In lateral 1/3 of hand. So sir, we use the term for this condition, what we call this a group of disorder called entrapment neuropathy.
Yeah, entrapment neuropathy.
So I will call this as entrapment neuropathy. Now you can see the position where it is in the wrist. So whenever this is occurring in the wrist, this is like a case of carpal tunnel syndrome. So carpal tunnel syndrome is an example of entrapment neuropathy, and this will definitely occur. What will happen when your pressure is increased? It is above 30. It means it will compress more nerve. So this is a condition which is a correct statement. More the pressure, there is more chance of compression and there will be neuropathy. Now coming to second option, sir, Finkelstein test.
The range of tests, all the clinical provocative tests for diagnosing the carpal tunnel syndromes are related to the compression of the median nerve further by the application of the pressures. Now, out of the multiple tests which you should be aware of, because it is a very frequently asked question nowadays and all related to the test of the carpal tunnel syndrome in particular, the first one is the Fallon test that we already are aware of. Like if there is a flexion of the wrist against each other, thereby compromising the space available for the median nerve is further reduced, as a result of which there will be more compression of the median nerve, and if it is compressed for 1 minute, there will be provocation of the exaggeration of the tingling and numbness the patient was experiencing. So this is Fallon test. Exactly opposite to this is a reverse Fallon test, where the wrist is not flexed, the wrist is extended and is getting compressed. But only difference in between the two is the time duration. For making the diagnosis of Fallon, CTS by Fallon, 1 minute is required. While making a diagnosis by reverse Fallon, 2-minute compression is required. Then comes the third sign, that is Tinel sign again. When you tap along the course of the median nerve from distal to the proximal end, there will be the abnormal sensations in the form of paresthesia and tingling felt in the area of distribution. Now, majority of the time, the students are confused that is it the abnormal sensations felt over the area tapped? No, it is never the abnormal sensation felt over the area tapped. It is the abnormal sensations which are felt in the area of distribution of the nerve which is being tapped. So that is a Tinel sign positivity. Durkheim test you already are aware of, that it is already mentioned in the question, like if there is a manual compression of the wrist for the period of 30 seconds, it will provocate the symptoms, it will exaggerate the features. So this is again a test, and the application of the tourniquet, which is a Gilead test. If here the application of the tourniquet in the arm will again provocate. So all these are the provocative tests for the diagnosis of carpal tunnel syndromes.
Now coming to our question, you can see Finkelstein test.
Means it is Finkelstein's test which is written in the question, and Finkelstein test is for making the diagnosis of de quervain tenosynovitis. It is not for the carpal tunnel syndrome. Already you are aware what is de quervain tenosynovitis. It is the compression of the abductor pollicis longus, extensor pollicis brevis within the first compartment of the extensor retinaculum. So this Finkelstein test is for de quervain tenosynovitis, not for the carpal tunnel syndrome.
Okay, so let's see the other options as well. Electrodiagnostic studies means what we have nerve conduction velocity. So basically entrapment neuropathy we diagnose by doing this test. So that is the gold standard test. So this is, I can say, a correct statement again. Now fourth option, sir.
As far as the management of the carpal tunnel syndrome is concerned, it can be managed by immobilization for some duration of time. If it is not helpful, then the ultimate management for CTS is to open the flexor retinaculum, is to release the flexor retinaculum. Open release is considered to be the gold standard management. Now there are some endoscopic managements also by one or a single or a two portal systems, but this endoscopic release of the CTS syndrome is having an advantage of less postoperative pain. It is having the advantage of less scar pain or the pain which is related to the scar, but the learning curve is too steep, and as a result of which there is increased complications associated with the, and there is also a possibility of recurrence because of not the complete opening of the flexor retinaculum. So endoscopic carpal tunnel release has a greater complication, slightly greater complication rate compared to the open carpal tunnel syndrome release. And after some duration of time, when the learning curve is going to be reduced, then possibly the endoscopic is going to prevail over the open release of the CTS.
So this will be a correct statement. So a few more information about carpal tunnel syndrome. So remember, there are some systemic disease which they often ask in exam. So out of this, the important one, remember the first thing, like they ask you sometime a question like whenever you see a case of entrapment neuropathy, first thing is rule out diabetes. High blood sugar is a classical risk factor. So you should rule out diabetes. Then what else we have to rule out? We have to rule out rheumatoid arthritis, gout, non-specific tenosynovitis, amyloidosis. This question I have seen 2 to 3 times in exam. You have to rule out some of the tumors like gangliomas, lipoma, fibromas, and sometimes it can be like after dislocation or fractures. So these are some condition, but here they will ask you like systemic disease like gout, RA, amyloidosis, SLE, and even diabetes. So these are the things which you should rule out before making a diagnosis of isolated carpal tunnel syndrome. Is it clear? So mostly like it is not, it is generally associated with some infection or some trigger, some trauma or some disease or some systemic illness. So it is definitely an association with carpal tunnel. So then I told you of the electrodiagnostic study. What we do nerve conduction velocity. So out of this 3 features like prolonged conduction velocity, increased duration of action potential, and polyphasic contour, if any 2 are present, 2 or more are present, that is sufficient to make a diagnosis of carpal tunnel syndrome. Okay, coming to this, I already explained this part. Now coming to the next question that is related to ankylosing spondylitis. So what is incorrect statement?
This question, as majority of you might be aware, that every year if you are sitting in the examination, you will get a question related to ankylosing spondylitis, and why is the reason, means over a period of time, again and again we are emphasizing that why are we getting this question. The reason is to make the diagnosis earlier, to prevent the patient from disability. All right. So ankylosing spondylitis is a condition that has to be diagnosed as early as possible. And if we look at the option number 1, for making the diagnosis, we have got the modified New York criteria and the ASAS criteria. And in the option which is provided, that modified New York criteria helps in making the early diagnosis compared to ASAS. Now, if we look at the modified New York criteria, this criteria requires, now all of you are aware that low backache and stiffness which is persisted for a long duration and it gets improved with the activity is one such criteria. Limited range of movement in the lumbar spine in forward bending and the lateral bending, Schobert's test positivity is a criteria. Limitation of the chest expansion. So all these things, they come late. Now as far as the sacroiliac features are concerned on the x-rays, it will also take time for its appearance. So all these features combined with the x-ray findings, they are responsible for making the diagnosis late over a period. All right. By the time you make the diagnosis, there is always a possibility that some segment has already been ankylosed and the patient will be left with a permanent disability. But if you compare it with the ASAS criteria, here we are having the spondyloarthropathic clinical features. If they are present along with the sacroiliitis in the form of a clinical feature, that the diagnosis is made. And as far as investigation is concerned, the early erosion findings are also going to be identified on the MRI. So, sir is going to explain about the extra articular clinical features of ankylosing spondylitis in the next option. But here what is the essence of talking about these 2 diagnostic criteria, that ASAS actually makes it possible to diagnose the condition earlier in comparison to that of the New York criteria. So, if we look at the option again, that option number first, modified New York criteria helps in making early diagnosis. No, it doesn't help in making early diagnosis compared to that of ASAS.
So we got the answer already. So before reading other options, just a quick overview of ankylosing spondylitis. Like in any arthritis, this rheumatoid factor, if it is present, we call this as seropositive. Seropositive means that will be your rheumatoid arthritis. If this rheumatoid factor is absent, then we label this as seronegative. And the seronegative arthritis, we have some conditions here. Seronegative arthritis. So seronegative means rheumatoid factor is negative. Seropositive is rheumatoid arthritis. So here we have diseases like juvenile form of rheumatoid arthritis. We call this JRA. Then we have ankylosing spondylitis, AS. Third is IBD associated arthritis. E will be psoriatic arthritis. U is undifferentiated form of arthritis. And R is your reactive arthritis, which we sometimes call Reiter syndrome. So this is Jaipur, a mnemonic for seronegative arthritis. Ankylosing spondylitis is one of the seronegative arthritis. So generally, how we make a diagnosis patient, we apply ASAS criteria. So like sir already explained the criteria. Now understand this, the disease will also have some extra articular manifestation. So many times, like patient, the most common finding you will see, the patient will complain of uveitis, anterior uveitis. Then there can be a risk of glaucoma, cataract, and this is the MCQ which they ask again and again. There can be aortic valvular insufficiency, and sometimes they will give you in the option dilated cardiomyopathy. So remember, DCMP is not seen, aortic valvular insufficiency is seen. They can give you options like third degree heart block, prostatitis. There can be ileitis or inflammation of colon, colitis. There can be pulmonary fibrosis. There can be retropulmonary fibrosis. So these are all extra articular manifestation, but you have to remember at least these two, because these two are repeated questions. They ask again and again. There will be aortic wall insufficiency, not mitral, and there will be anterior uveitis. So these are some of the extra articular manifestation. Now let us see other options. Aortic valve disease is the feature of disease. This is a correct statement. If you see NSAID,
Yeah, NSAIDs fail to decrease the progression of disease. You see, no drug except for the TNF alpha inhibitors, that too if they are given in the early stages. So no drug is responsible for decreasing the progression of disease. It just can limit the inflammatory arthropathy symptoms, which are going to be helpful in making the patients more mobile and symptom free. So obviously this is the correct statement.
NSAID will provide symptomatic relief. That is, they will just control the pain and they will reduce some sort of inflammation. But remember, you cannot treat the root cause because of by using NSAID. So coming to our next option, leukopenia and reactivation TB are known complications. That is true. To understand, whenever we use drugs like TNF alpha inhibitors, so we have drugs like abatacept, etanercept, infliximab, golimumab, certolizumab. These are the drugs that act on TNF alpha. So whenever you give this drug, there are three problems which you need to face. First is there is reactivation of infection. Reactivation means there is chance of reactivation of TB, even sometimes there is chance of reactivation of hepatitis. So always do the screening of hepatitis B, C and screening of TB before giving this test, giving these drugs. Second possibility is there is leukopenias. So there will be some sort of immunocompromisation, leukocytes count are less, so there will be patient will be prone for infection. Third thing is whenever a person is taking TNF alpha inhibitors, especially by IV method, by parenteral route, then there is a problem like there is chance of infusion reaction. Many times you will see patient will develop infusion reaction, so always first give the tested dose. So remember, reactivation of TB, hepatitis, leukopenias and infusion reaction, these are quite common with TNF alpha inhibitors. So again, this is a correct statement.
The real essence of ankylosing spondylitis, if we just try to understand the terminology, ankylosis means pathological fusion of the joint, spond means the axial skeleton, itis is the inflammatory pathology, so it is the inflammatory pathology of the axial skeleton that will result in pathological fusion. And what you have to prevent this fusion in order to prevent the disability that can happen in the patient. That is the real essence why they are asking this question again and again. So hopefully you get the answer for this question, very well explained by sir. Answer for this question is obviously A, which is incorrect statement.
So we prefer this criteria, ASAS criteria, not a NEO criteria. Okay, so like this is the medical management. NSAID will provide symptomatic relief. Then sometimes we can use DMARD, but again the effectivity is like mostly what we use can use methotrexate, we can use steroid, we can use TNF alpha inhibitor. But make sure before using TNF alpha inhibitors, you should do the test dose. Okay, coming to the next question, which of the following serum test is most useful in diagnosis of Paget disease? So let's see the option one by one. Parathyroid hormone we check whenever we suspect a case of primary or secondary hyperparathyroidism or primary secondary hypoparathyroidism. So it's not a case of parathyroid hormone disorder, so we will not check this. Lactate dehydrogenase level. Lactate dehydrogenase level, LDH is a non-specific enzyme, so this can be increased in many hemolytic anemias. This is also a marker for myocardial infarction. We call this flipping of LDH, that is LDH1 will be more than 2. So it is a non-specific thing, so we don't do this. Phosphate level we will check whenever we think about a condition like rickets, osteomalacia, or we think about a condition called hypophosphatemia or hyperphosphatemia. So how we make, what test we do? We do alkaline phosphatase, serum alkaline phosphatase, which is what we call this bone specific alkaline phosphatase. So that is a test that we do to make a diagnosis of Paget disease. Okay.
Yeah, as the Paget disease means osteitis deformans, where there is increased rate of turnover of the bone, there is increased formation of the bone and there is increased resorption of the bone. So both the markers of bone formation and bone resorption are going to be elevated. And in this condition, because there is a persistent increased rate of or the velocity of the bone formation, that is the reason why bone specific alkaline phosphatase are always found to be elevated. As far as other options are concerned, they are related to the metabolic activities or metabolic conditions of the bone, where there is decrease in the density of the bone.
Okay, sir, just I want to add here something. Paget disease, the name we use in many other places other than medicine orthopedics. So we can have Paget disease of bones, which we already discussed. There is a Paget disease of breast. That is like an invasive form of breast cancer. So we can have Paget disease in the breast. Where else Paget disease can occur? Anyone? Can you answer? It can occur in penis and it can occur in vulva. So these are other sides. Remember, just remember this. We can also have Paget disease of penis, vulva, breast, and the bone. But the bone form is different from others. Is it clear? And this Paget disease of breast, it is a malignancy. Remember these lines. Okay, coming to next question. So
in the next question, like 26-year-old male admitted patient, you know, they have given you the age and they have already described that the patient is admitted with the fracture of the right femur, right tibia and fibula and the left femur. So the patient is a polytraumatic patient where multiple long bones are fractured. Developed fever, increased respiratory rate. So as a resident medical officer, what you have identified that an admitted patient is developing the increased respiratory rate as well as the fever. On examination, he was found to have the petechial lesions. You know, by the time you have read the statement, you already know that the diagnosis the patient could be suffering from is the fat embolism syndrome. Because the cardinal feature of fat embolism syndrome is the appearance or you can say the pathognomonic feature of the fat embolism syndrome is the appearance of the petechial lesions over the trunk, abdomen as well as axilla. It can also be seen in conjunctiva as well as retina. But the alarming features always are tachypnea, tachycardia and fever. Tachypnea, tachycardia. Just imagine a long bone. So all these are hints provided. Long bone, multiple long bones are fractured. Patient developed tachypnea, tachycardia or fever and petechial lesions are identified. Answer for that question is fat embolism syndrome. So they are asking which of the following is incorrect for the condition. So obviously we have made the diagnosis that it is fat embolism syndrome. Anything, sir, that you want to add in this question in particular?
Sir, just I want to add, like, you know, how we make a diagnosis of fat embolism. So generally we make, it's a combination of like clinical symptom and lab findings. So we use a criteria for this, that is GERD criteria. GERD criteria we used to make a diagnosis. Now let us see the options. Incorrect they are asking.
Yeah, they are asking about the incorrect options, like get a valid consent with unprecedented outcome. As you know that if there is an emboli, it might result in respiratory distress syndrome, the coma, patient might get comatose and eventually death of the patient. You know, just a patient who is admitted to get the surgery done is getting this much complicated that he is about to die. So always get a consent, written consent with unprecedented.
Needed before any surgery. So that is like, you know, we have already ruled out the option.
A high risk consent has to be required, explaining it to the attendants. Now, sir, next option.
So it's an embolus, so it can migrate to lungs, it can migrate to brain, it can produce brain stroke, it can produce I can say respiratory compromise. Patient can die because of cardiopulmonary arrest or because of brain arrest. So that is why we should always be ready with the oxygen assistance. So this is, I think, the correct statement.
Yeah. And prepare the patient for the surgery. You know, if we leave the patient, like this is also a possibility, like if we leave the patient for too long with instability at the fracture site, then it will increase the possibility of these emboli to get or to reach the circulation.
Multiple emboli will
Yeah.
be formed.
So previously it was considered to be a contraindication, like performing a surgery on a patient who might be developing this fat embolism was considered to be a contraindication previously. But now, after multiple trials, it is found that it is having a greater advantage to immobilize the fracture by performing early surgery without any reaming. So early surgery, or if you perform a surgery, it is no more a contraindication. All right, once you have understood or once you have explained it to the patient as well as their attendants. So that option is also correct.
Okay, reading the next option, urine analysis alone will not diagnose this condition because it's like we need many clinical features. Then we have to do many testings, only then we can make a diagnosis. So alone urine analysis will not make a diagnosis. This is an incorrect statement about a fat embolism. Okay, then coming to next question, sir.
A 55-year-old diabetic male came to, so first of all, etiology, diabetes already mentioned in the question, came to OPD with the complaint of pain, swelling, tenderness over the lateral aspect of the right ankle, with the skin discoloration present, with limited dorsiflexion and inversion of the foot. Dorsalis pedis is not palpable. Which of the following is incorrect? So, sir, let's have a understanding of the differential diagnosis that the patient could be suffering from.
Okay, sir. In this question, you can see like patient is having history of diabetes. So you can understand like diabetes, neuropathies are very common. So first differential, it could be a case of Charcot joint. So you can see like it could be like a neuropathic joint disease. We call this a Charcot joint. Or a second thing, like here they are mentioning like this dorsal pedis artery is not palpable. So if it is not mentioned, but it could be like some PVD. PVD means peripheral vascular disease. It could be like a peripheral vascular disease. It could be like an impending gangrene in a patient of diabetes. But they have not mentioned about gangrene.
Yeah, because they have not mentioned anything which is related to the etiology like smoking or there is gangrenous clinical features which are mentioned in the question. So nothing is sort of that sort is provided. Now the patient has got disintegration or degeneration of the joint, which is seen because of there is a limitation of dorsiflexion and inversion of the foot. So there is some abnormality. In case a patient is having a PVD, the movements are going to be normal. They are not going to be affected. That means we are talking about a condition which has resulted in the arthropathy, the joint destruction. Now, if it is coupled with diabetes mellitus, all right, and there is pain, tenderness and swelling because of repeated injuries, then it is a case which probably goes in the favor of neuropathic joint disease or Charcot arthropathy, because in this particular disease what happens, there will be a loss of pain and proprioception pathways, as a result of which the joint, particularly the ankle joint, is subjected to repeated injuries, and those repeated injuries will result in the destruction. That is why neuropathic joint disease, that means pathology is there in the neuronal system, but it has resulted in the joint destruction. So if we look at the option number 1, the sir will explain obviously.
So like it is like a chronic disease. So you can see repeated injuries are quite common. So we will advise, of course, to every patient with diabetes. Like in fact, in US, in Europe, you will see like we appoint a specialist called feet experts. We call them podarists. So they will advise a proper foot care. Diabetes, because they are prone to get atrophic ulcers, they can develop peripheral vascular disease, they can develop gangrene. So appropriate footwear is needed, and of course the most important factor in preventing these complications is strict glucose control. So the target HbA1c, remember, the target HbA1c should be less than 7. So whenever we are treating a patient of diabetes, so the gold standard test nowadays is HbA1c, so this should be less than 7%. So this is needed. Now coming to next option, sir.
I mean, obviously,
I can make it correct by ruling out, but I have no idea about Sarmentia amputation.
you know, obviously you are not going to amputate a patient who is having no dorsalis pedis palpable until and unless the foot has already been gangrenous. All right, and there is no feature of gangrene which has been mentioned in the question. So performing amputation is going to be too much for this kind of a patient. You just have to manage the patient in order to prevent the repeated injuries and a strict control of the etiology which has caused the condition, and limit the pain of the patient or the discomfort of the patient. The essence of providing this question was to identify it by ruling out the other differentials, and it is very, very commonly asked kind of a question which the patient fails to recall that where exactly the question was asked from, like neuropathic joint disease. So hopefully you get the answer. You are not going to perform this Sermancio or the Symes amputation. Sermancio amputation basically is the above ankle amputation, 13 millimeters above the level of the ankle joint.
So like even if you don't know about Serman sample, you can mark the answer correct. So the same thing you have to believe in your exam. Like we all are like human beings. We can't know everything, but like I can make the answer correct. You can also do the same thing. Because these are some fact-based information, right? So let's discuss something about neuropathic joint disease or Charcot joint. So this is what we see. We see painless destruction in the joint. It is classically seen in patient of diabetes, tabes dorsalis, amyloidosis, leprosy, syringomyelia. So these are few conditions. Sometimes they ask you question like all except fashion. They'll ask you question all are causes of Charcot joint or all are causes of neuropathic joint disease except. So these are the condition where you can see Charcot joint.
And they used to give tuberculosis in the options very commonly because tuberculosis is not the cause for this neuropathic joint disease. Sir.
Okay, so let us discuss some clinical case. So 50-year-old male. So starting with the hint, you can see 50 years. So age itself is a hint. Present with inflammatory monoarthritis. So when you see the word monoarthritis means what is ruled out? Rheumatoid arthritis is ruled out. Rheumatoid arthritis is generally polyarticular or polyarthritis affecting right ankle joint. It's affecting right ankle joint. Following is the best test. Okay, so when I see a case of monoarthritis, so always remember one thing. Common things are more common in exams. So common diseases are more common, or common symptoms of disease are more common than uncommon things. So first you have to focus on common things. So when you see this type of question, you have differential in your brain. It could be osteoarthritis, which can be a monoarthritis, or it could be a case of gout. These are two differential in my brain till now. So when I see serum uric acid level I can check. But remember, in gout, when you see this uric acid is going to be deposited in the tissues. So when you see this in the blood, it may be normal, sometimes it is low, sometimes it is increased. So this is having no value. Even like a common mistake which I am seeing by many physicians is whenever they see like uric acid level above 7, what they straight away they start the drug called febuxostat or allopurinol. There is no point of starting. Remember, asymptomatic hyperuricemia, if you see in a person, the chance he will develop gout will be very less, and that too will be after 15-20 years. So when you see such patient with having a slight uric acid elevation, just advise the patient to hydrate himself a lot, drink a lot of water, avoid some triggers like smoking, red meat, some sucrose, fructose containing food. So these are the things should be avoided. So remember, there is this is like I am seeing a lot of mistake in many people. What they start febutas, febuxostat, allopurinol. So asymptomatic hyperuricemia, there is no point of treatment. Just try to change your lifestyle. Serum calcium level, again, there is no point of checking this. Serum calcium level, we check when we suspect any cases of acute or chronic, I can say hypocalcemia, not here. Even we don't check this in any form of arthritis. Like I can say in rheumatology, we check serum calcium level in sarcoidosis. Because sarcoidosis, that's the granulomatous inflammations that will have formation of granuloma. This granuloma, you will see that will increase production of calcium. ESR, CRP, so these are your positive acute phase reactant. Positive acute phase reactant, so this can increase in rheumatoid arthritis, severe form of acute arthritis, or I can say any arthritis. So this is like non-specific positive acute phase reactant, so they can increase anywhere. So this is like we are imagining or assuming it's the case of gout, because options are giving close to gout. This is option close to gout, pseudo gout. Then the best test, the best they're asking, the best test for diagnosing gout is synovial fluid aspirations. So you will aspirate the synovial fluid. Then you will look this under polarized light. You will see needle shaped negatively by reference crystals. That is how we make a diagnosis of gout. Okay, sir. Coming to next question, again a clinical case. So let me see the question first. You can see the age of the person, 10-year-old, with 1 week history of both knee joint. Both knee joint involvement. You can see pain started with the right knee and involved the left. Within a couple of days, further history of burning micturition 3 weeks back. Urine culture done twice, but it was sterile. So it is a case of sterile pyuria. So just by looking the sterile pyuria, don't mark the answer TB. It is seen in many other conditions. So now understand this. This is, you can see the nutshell summary of this case is, you can see the patient is having UTI or cystitis. This UTI or cystitis, then later on is having arthritis. UTI, which is progressed to arthritis. So this is like we call this as reactive arthritis or Ritter syndrome. so which is generally preceded by I can say UTI or GIT infection. So why answer is not septic arthritis? Understand this. There is you can see the patient in septic arthritis. You will see the patient will be febrile. There will be leukocytosis. There will be a swollen, a painful knee joint. So this is you can see UTI is quite common after chlamydia infection. So chlamydia, ureoplasma, mycoplasma, even sometimes Campylobacter, some GIT infection, they can cause a condition called reactive arthritis. So the answer is reactive arthritis. Rheumatoid arthritis can have mycoplasma as a trigger, but again you can see the age of the patient, it is not the diagnosis. Enteropathic arthritis you will see in a patient of IBD like Crohn's disease and ulcerative colitis, but again that is not related to E. coli infection. So just remember a classical triad. However, this triad is not seen in practice, but still they ask an MCQ. Can't see means patient will have conjunctivitis. Can't pee means there will be urethritis. Can't dance with me means there will be arthritis. So this is a triad that we see in a patient of reactive arthritis. The other complication you can see the patient can develop keratoderma ablenoregica. This is something that we see in palms and soles. So you can see the painful lesions in palms and soles of skin. And circinate balanitis, this is seen in penis. Here also patient can develop sausage digit. Sausage digit, remember, they are also seen in a case of psoriatic arthritis. So this is like a simple overview of reactive arthritis. Reactive arthritis, or we call this Ritter syndrome. Coming to next question. So again a clinical case in front of you. So let me read the question for you. 55-year-old man present to you with 2-week history of pain in his hand. Pain is particularly bad in his right hand. On examination, brown discoloration of his nail with onycholysis. So this is the biggest hint. So when I see this word onycholysis, I made the answer. And DIP is involved. So remember this DIP is involved. So you can see, you can also solve this question from your dermatology. What we see, you can see the patient will have in psoriatic arthritis, you will see something like nail changes are very pathognomonic. So what we see in the nail change, you can see like patient with psoriatic arthritis. I'm not talking about psoriasis, psoriatic arthritis. So you will see like patient with psoriatic arthritis, they will develop onycholysis. There will be separation of nail from nail bed. There will be onychorexis, there will be onycholysis, and sometimes what we call this oil drop sign. That is a classical hint in the MCQ. So this is a case like you can see, and the most common joint involved in psoriatic arthritis is this is your DIP. So that is why this is a classical case of psoriatic arthritis. Okay, just few more things just I want to add here. You can see the diagnostic criteria, we call this Casper criteria. The patient will have current psoriasis, there will be nail dystrophy, negative RA factor, so that's why like we call this as seronegative. There is dactylitis, and sometimes you can see new bone formation. So this diagnostic criteria that we use is Casper criteria. So classical case, okay, just I'll add here some of the criteria that we use. Like I told you, Casper criteria. Casper criteria we use for psoriatic arthritis. Then remember we have ACR Euler. ACR is American Colleagues of Rheumatology, a European League Against Rheumatism. This is the criteria that we use for rheumatoid arthritis. ACR Euler. BAS-DIE. This BAS-DIE index, BAS-DIE criteria we use in a patient of ankylosing spondylitis. Ankylosing spondylitis. So these are some of the criteria, named criteria that they can ask you in exam. Coming to again a clinical case. So you can see this type of case is very common in INI-CET type. So theme and focus. So focus on arthritis. So these are the options. So first here there are A, B, C, D, E, F. So you can see a lot of options.
Yes.
So and there are 3 clinical cases. So this is like a question which if you mark correct. So this question, remember, is having huge weightage.
Multiple options are provided, and you have to, there are 3 case scenarios which are provided. These 3 case scenarios, out of them, one of the option has to be attached to that particular case scenario. Like in the case number 1, a 54-year-old lady came with a history of diabetes mellitus, acute painful knee swelling which improves with activity. You know, for this kind of a question, first of all, we have to isolate the three options, or at least the options which are provided. One, it could be rheumatoid arthritis. Second, it could be a pseudo gout because there is involvement of the knee joint. And third, it could be osteoarthritis. All right. Now we have to decide whether it goes in the favor of rheumatoid arthritis, osteoarthritis, or the pseudo gout. Now, on examination, there is a restriction of the movement, and X-ray shows the periarticular erosions. Although it is very much all these features are overlapped, there is no point which is provided which will make sure that this is the diagnosis. But in case if there is an increased, or if the knee swelling, it improves with the activity, then it goes in the favor of inflammatory arthropathies, like it goes in the favor of rheumatoid arthritis. In case, second is that in case if osteoarthritis or any degenerative condition would have been asked, then they should have given you the reduction of the joint space. They must have provided the joint sclerosis. They must have provided the abnormalities in the shape, progressive abnormality. So the case scenario number 1, it goes in the favor of rheumatoid arthritis.
This is a case of RA. Coming to second case, a 32-year-old lady with joint pain. Young lady, joint pain, oral ulcers, aphthous ulcers, skin rash that worsen when she move out, means photosensitivity. So I think all of you are knowing this. This is a case of SLE. Why SLE? You can see again, young female. So there is a young case, young female. SLE is more common in young female. Then you can see there is arthritis. So we see arthritis in a patient. You can see oral ulcers and photosensitivity. So these are all features of SLE. Coming to next case, sir.
The third case is a 42-year-old man with a history of 10 years of low backache. On radiology, bilateral fixed sacroiliac joint. That means there is a fusion of sacroiliac joint which has already happened with syndesmophytes. That means the bony erosional findings in the lumbar spine. And once you see the sacroiliitis mentioned in the question, then possibly they are asking about ankylosing spondylitis, and all those clinical features goes in the favor of ankylosing spondylitis. You see, if someone is asking about ankylosing spondylitis and they have not mentioned sacroiliitis in the question, possibly it is not ankylosing spondylitis as the answer that they are asking about. It has to be there in order to make the diagnosis. So answer for this question obviously is the ankylosing spondylitis.
So one more hint I want to just focus, like as per the ASAS criteria, what we have, the classical thing is, if you notice, I told you about the age. The age of the patient should be less than 45 years, and here it is given 42 years. So to make a diagnosis of ankylosing spondylitis, it is generally a person who is less than 45 years. So this is the case of ankylosing spondylitis. Clear? Okay, coming to next question. So which of these is associated with recurrent bout of acute attacks? So this question, like again a one-liner, but why I added this question? Because this question came twice in INI-CET exam. The first question was simple, like which is the metal, or this metal I can say is lead. So whenever, remember, a patient who is taking lead, this lead toxicity can precipitate gout. And this type of gout is called Saturnian gout. So this was the next question which came in exam. The first question is in front of you, like which of these metal? The answer was lead. Then the next attempt they have asked the question, Saturnian gout is due to, the answer is again lead. So remember this, so that like this question came 2 to 3 times in past 3 years. So that's why I added this. Recurrent bout of acute gout is seen with which metal? That is lead. Clear? Okay, so next question, sir.
Vitamin D, this is every time we talk about rickets, majority of the time it is nutritional deficiency, ricket related questions you are getting. But this is a time where we have to discuss about the other possible reasons for the rickets. And this is vitamin D dependent rickets type 2. You already know there are 2 types of vitamin D dependent rickets. One is type 1, where there is a deficiency of the enzyme alpha-1 hydroxylase, which is responsible for converting the vitamin D2 into vitamin D3, and the D2 is end organ resistance. So here we are talking about type 2, which is end organ resistance, and which of the following is incorrect. So basically we are learning the topic in this particular question. Now if you look at the option number 1, alopecia, you know how the clinical features are differentiated from that of the more common nutritional deficiency ricket, that no muscular weakness, muscular weakness is always a feature of nutritional deficiency ricket, and no muscular weakness is a feature of vitamin D dependent rickets type 2. Then severe limb deformities, which is progressively severe limb deformities, but the highlight over here is alopecia and dwarfism. Alopecia, yet yes, it will happen. Dwarfism because of the short limbs. Now here the dwarfism in case of vitamin D2 dependent ricket is not a peculiar type of a dwarfism that we get in a genetic conditions. Here, like in case of achondroplasia, it is a rhizomelic shortening, where the trunk is larger, the limbs are smaller. Here, the patient could be having small limbs, the patient could be having a small lower limb, like it is a disproportionate kind of a shortening which the patient could be having. So these are the clinical features, goes in favor of vitamin D dependent rickets type 2. Second is normal alkaline phosphatase, the high vitamin D3. Why there will be a high vitamin D3? Because this D3 is not able to act on end organ. All right, there is end organ resistance. So there is a continuous feedback which is responsible for creating this vitamin D. So this is a kind of a rickets where serological value of vitamin D3 is found to be elevated multiple times. And increased PTH, which is a secondary increase in the parathormone because of the decline in the calcium in the blood overall. Now, as far as this option C is concerned, the phosphorus, it never returns to normal. This is one such feature which goes in the favor of vitamin D dependent rickets, VDDR. We are talking about this VDDR type 2. And if phosphorus is always found to be decreased and it never returns to normal even with prolonged treatment with high dose vitamin D. How high dose vitamin D has to be provided for a long duration of time in order to manage this condition. And obviously this is the answer for your question, because deficiency of the enzyme alpha-1 hydroxylase is the feature of vitamin D dependent rickets type 1. It is not the feature of vitamin D dependent rickets type 2. Here in type 2 we are getting end organ resistance. So be ready for this kind of a question in your future examination, where they will be asking the other reasons for rickets apart from nutritional deficiency rickets.
So correct answer for this question, you can see the statement is incorrect. So answer will be D. Okay, coming to next question, following statement about Tofacitinib are true except. So Tofacitinib is a new drug that even nowadays it is not new, sir, right? We are using this in practice. So like it's one of the, I can say not as expensive as TNF alpha inhibitor. So it is a cheaper oral available drug. So that is why we very commonly use this drug in practice. So it is first oral agent inhibiting the inflammatory cascade in rheumatoid arthritis. Is it an oral inflammatory agent? Yes, this will suppress, because others, most of these drugs are biologics, they are given by parenteral route. It acts by, so this is a correct statement. It acts by stimulation of JAK2. This is the wrong statement. It acts by inhibiting JAK1 and JAK3. It is basically JAK1, JAK3 inhibitor, not JAK2 inhibitor. So this is the answer. It is approved in India. We are using this, like sir, for how long you are using this?
Sir, for the last 3 to 4 years, we are using the oral formulations of the Tofacitinib, and it is found to be more effective in comparison to the when it is added to the disease-modifying anti-rheumatic agents.
Even sir, I have used this drug in COVID wave 2, because when we were not knowing the exact treatment, so what we have, Baricitinib, Tofacitinib, we have used all these drugs. It is approved in India, yes. So this is approved. This is again, this is a true statement. It is also approved for treatment of psoriatic arthropathy. Yes, it is also approved. Like in all the inflammatory arthropathies, sometimes what we see, there is excess release of cytokines. What we call the cytokine storm. So in order to prevent that cytokine storm, we have to use these kind of drugs. So this is given. So answer will be, it is not acting by JAK2, JAK1, JAK1, JAK3. Remember.
Yeah, so because this thing is new, means there is always a possibility that they are going to ask these kind of a question, like Tofacitinib related questions, because it is very commonly used in practice today, and they will possibly ask about the mechanism, and they will possibly ask about the adverse effect of this drug.
Okay, coming to next question, sir. You can say
76-year-old man, he presents to the emergency department with a pain in his, so there is an acute flare in the pain in the knee. He described the pain as worse in the evening after exertion. On examination, Herbedin nodules are present. The two nodules, one is Bouchard and the other one is Herbedin. Herbedin nodule is the involvement of the distal interphalangeal joint of the finger by osteoarthritis, and the Bouchard is the proximal interphalangeal joint involvement in the finger by osteoarthritis. So these are the two nodular swellings which are characteristic for osteoarthritic abnormality. So X-ray shows reduction in the joint space. You know what they are asking is simply that they are in the question itself they are asking that are you aware of the X-ray features of the osteoarthritis knee joint? So there will be a reduction in the joint space, subchondral sclerosis, osteophyte formation. All these are basically the X-ray findings of the osteoarthritis in the knee joint. What is the most appropriate management? So by looking at this condition only, now you have to decide using the statements which are provided in the question that which one is the apt management at that particular time. So one, anti-TNF alpha therapy. Nowhere it has been mentioned that it is a condition which is related to the inflammation. So nowhere it has been mentioned. And Herbert nodules is not an inflammatory condition. It is osteoarthritic degenerative condition. This botanier deformity or the swan neck deformities are the deformities which are related to inflammation, but here Herbedin and the Bouchard are the osteoarthritic abnormality. NSAIDs and urgent orthopedic opinion. There is no urgency. You just have to wait. You can wait because it is the acute flare of the pain because of the massive swelling. There could be. So it is not an orthopedic urgency that we can go for or we have to go for. NSAIDs and the regular follow-up, because once there is a subsidence of the pain or the relief in the symptoms as concerned, then the patient can be asked to come for the follow-up regularly and to decide the management in the eventual course of time. So out of the multiple options provided for the condition which is not emergency, there is a possibility that this is the correct answer provided for the particular question. And sir, obviously the option D.
Okay, so just I want to add something here. You can see this is like if I make an image of the hand, you can see this is the DIP joint, and you can see sometime a node here, or sometimes you can see a node in the PIP joint. So when you see like this type of node, this Bouchard node is something which is in the PIP picture. So tell me if I am wrong here, or correct me.
Yeah.
This is Bouchard node, and this is the node what we see. We call this as Heberden node. And these two node where we see this in the case of osteoarthritis. Now understand, if you see in this question, this is like an acute flare of a condition called osteoarthritis. So whenever a patient is like these kind of patients, they are very common. They are coming into practice again and again. Sometimes they go to medicine department, sometimes they go to orthopedics, and what we both write them, we will write them like NSAID, calcium, vitamin D, and they will come again for follow-up. If it is like severe or life-threatening or like it's affecting, like there is a heavy weight, they are obese, in that case we will take an orthopedist opinion. Like sometime what we have to do, we have to plan for TKR or not. To understand, anti-TNF alpha therapy, this is not recommended. It is for rheumatoid arthritis and other inflammatory arthritis. Urgent orthopedic opinion we will do if it is affecting their lifestyle or if it is like not a stable patient. So regular follow-up is needed. DMARD therapy is disease modifying anti-rheumatoid drugs. So that is again we use for rheumatoid arthritis. So answer is simple. This is again this type of question you will not get in any book. It is like a practice-based MCQ.
Finally, we are having a 27-year-old male came to the casualty after sustaining fracture of the proximal ulna with the dislocation of the elbow. Fracture of the proximal ulna with elbow dislocation in itself, it goes in the favor of Montagia fracture dislocation. This is Montagia fracture dislocation. Now further they are asking on examination, the patient was not able to extend, so there was a loss of extension of the metacarpophalangeal joint and the sensations were intact. Anything which is related to the radial nerve injury, because extension of the metacarpophalangeal joint is a feature of the branch of the radial nerve injury. The extension of the wrist, extension of the elbow, all of them are the features of radial nerve injury. So possibly they are asking about the level of radial nerve injury, that where it is getting affected. Associated with Montagia fracture dislocation, the most common nerve which is found to be injured is the posterior interosseous nerve, which is a pure motor branch of radial nerve. And just by looking at the question itself, if the patient is having a sensations over the hand intact, it means there is an injury to the nerve which is pure motor. It is not involving the sensory component. So it is not a mixed nerve which is affected. So it is a pure motor nerve which is affected. So obviously the answer for this particular question is posterior interosseous nerve injury. And this question has been, these are the kind of the questions which you should be aware of. Like the sensations of the radial nerve are assessed over the first dorsal web space of hand, and they are giving in the option that in the question itself that there is no loss of sensations. So all these factors combined, you get this answer of posterior interosseous nerve injury in particular. Hopefully you get the answer for this question.
Okay, so this was our final question. So I hope you enjoyed the session. So this will be like again a summary that we have given. We have tried to get you on the right track so that you could not make any mistake in solving MCQs on neuropathy or arthritis part, or it could be a question on gout or pseudo gout. So mainly they want you to confuse. Just remember, just by seeing the like knee joint, don't be in a hurry to mark the answer osteoarthritis. Simple by saying like involvement of first MTP, do not mark the answer gout. So these are like common joint, but you have to read the entire question and try to make a differential in your brain. And once you know the differential diagnosis, remember your questions in exam. Rheumatology, or I can say like orthopedic, these are the topics which are easy questions in exam. This is the one topic in NEET paper we have seen there were around 4 questions from crystalloarthropathy, means gout and pseudo gout. There were 4 questions. So that is why we decided to take this topic, because we are expecting some questions in this INI-CET with the topic of gout or rheumatoid arthritis or osteoarthritis. There will be definitely some questions.
Yeah, because now the pattern is getting changed, and what the examiner is trying, that whatever the patients which are more commonly seen in the OPD or on the regular basis, they are formulating the questions out of those topics. Like in case of clinical conditions like orthopedics and medicines, almost majority of your question, like 40 to 50% of your questions are going to be the one which you have seen while sitting or while performing your internship in the OPDs. And these are the very, very commonly seen patients. And we try to modify it, try to make it more difficult so that you can easily answer the relatively easier questions. Hopefully you get the essence of what we have discussed today. All the best for.
So with this, we'll conclude our session. Thank you so much. Bye-bye.
Thank you.